Thank you all for joining. Today we're going to talk about OCD. OCD is often a condition um, that can be varied, and it often comes up in childhood and adolescence, but people um, can miss it at times because there's many different presentations of OCD. We're also going to talk about the family of OCD conditions such as body-focused repetitive behaviors, hoarding, body dysmorphic disorder, and the comorbid condition of chronic motor and vocal tic disorder and Tourette's disorder. We're going to talk about different ways to diagnose and how to develop a treatment plan that includes several of the modalities of psychotherapy and medications. We're going to start off talking about OCD. Now, at its core, OCD is a cycle and it involves both obsessions and compulsions. And you have to start off with distressing, repetitive, and intrusive thoughts. Now, these thoughts are by nature very distressing, and it's something that the patient wants to get rid of. And one of the ways they attempt to relieve themselves from stress is the compulsion. And that's where we get the cycle, where you have the obsession that's very intrusive, they cannot control it, it's very distressing, they engage in the compulsion, which initially is helpful. But what it does is it reinforces the OCD behavior, and the impairment can grow over time. There are very many different obsessions, which we'll get into later, and there's very much different compulsions as well. Additionally, there is a biological component to it, a psychological component to it, and a social component to it as well. So by social, I mean the environment the child and adolescent is in, the culture that patient lives in, school, the family connections, all of this can impact OCD. So before we move further, we're going to get into the definitions of obsessions and compulsions. An obsession is an unwanted thought, image, or urge that is recurring and intrusive. So, by definition, this thought causes anxiety, it causes shame. Patients feel very distressed and they're disgusted by the thought. So, this isn't something that they want, it's a thought that they cannot control, but it just keeps popping up and they just want to get rid of it. So this is an important distinguishing factor between other intrusive thoughts, such as ones that may come up in ADHD or other conditions where that thought that pops up doesn't cause anxiety and they might feel soothed by it. And then you also have the compulsion, which is the behavior. And the behavior is something that relieves them from these above conditions, the anxiety, the stress, the shame, or the disgust. And also, there is a superstition aspect to it, where if there's a thought that harm, for example, will come to somebody, or that they'll be feeling sick in the future, that the compulsion can help prevent that negative action, situation, or event. I'm going to list the OCD DSM criteria. It's important to be aware of it. In particular, the precise definition involves or. So sometimes people can have mostly obsessions or mostly compulsions that are present more often in kids and adolescents than adults, especially with the compulsions in kids. Kids may not have the language or the ability to voice fully the obsessions. The obsessions are there. The child just has difficulty expressing it. Now, the time consuming is also an important distinguishing factor, especially with impairment in functioning. This is more art. There's no set guideline for it because a lot of people without OCD check things. Many people check the door 3 or 4 times before they leave the house. They may hand wash a little bit longer than their friends. That does not necessarily mean they have OCD. OCD has a significant level of distress and it negatively impacts their friends, their work, their schoolwork, and their hobbies. You can often measure it in terms of timing. So people with OCD spend half hour, an hour on a given compulsion per day. So asking that time question can make a big distinguishing difference in impairment. Um, you can distinguish OCD by level of insight and whether there's a tic disorder that's present. So here are some of the examples of obsessions in children and adolescents. The more common ones are in bold. So I've had quite a few kids who've worried about going to the bathroom because of feeling dirty, or they're worried about bringing germs home and either getting themselves sick or another person sick. People can have a lot of obsessions involving symmetry. This can be their face being symmetrical. It can be the words on the page being symmetrical. It can be rearranging numbers because, or words on a sentence because the sentences need to have a certain number of words in it, or a sentence can't end in a vowel. A lot of times people can have intrusive sexual thoughts or intrusive religious thoughts. And these are obsessions that children are not necessarily going to voice. They're going to have a little bit more difficult time explaining this or discussing it without being specifically asked. So a lot of times people can have an intrusive thought of touching somebody else or have an intrusive thought that they're about to steal something or intrusive thought that they're not going to go to heaven or that they're going to commit some type of criminal act. I've had one adolescent have the intrusive thought that they're going to jail. And if they want to prevent themselves from going to jail, they have to apologize to their friends. And that was the compulsion. So a lot of times these obsessions can have a social component to it other social component to it. Another obsession example is a thought of hurting others. And I've had seen this in the emergency room where a person had an intrusive obsession or intrusive thought of hurting somebody else. And it's very stressful. They're never going to actually act on it, but that obsession was very much impairing. A lot of times people can develop obsessions about objects being arranged just right, the house being unlocked, checking the stove, and doing a test wrong can often come up in children and adolescents. I've had a few kids that could not move beyond the first two or three questions on a test because they kept redoing it, they kept checking it, they kept rearranging the answer. Um, and a lot of people can have obsessions that may mimic a psychosomatic disorder, such as they need to breathe a certain number of times. They need to swallow every 5 minutes, or they need to walk in or out a door a certain number of times. So we have these obsessions, and there's a lot of compulsion examples as well. I've already mentioned some of them, especially the ordering numbers and objects. There are some adolescents that rearrange um, numbers on a math test. They can often do reassurance seeking, so asking other people if they did something wrong. Or, like I mentioned, the child walking in and out of a room, he felt like he needed to walk into every room 5 times to help prevent harm from coming to somebody else. And repeating statements itself can be a mental status exam finding of someone with OCD. So, repeating the same phrase 5 times. I've had people knock on wood I've had people have to count things 5 times, or they prefer to think of things in terms of prime numbers. So there's a lot of um, compulsion examples that teenagers would describe as superstitions. And, a lot of people out and about have superstitions that are not OCD, going back to the impairment question, but it's compulsions that take up 30 minutes, 45 minutes. The hand washing can last up to an hour. People with OCD can often use up a whole bottle of body wash in one um, day in the shower. So some things that is good to ask, we already talked about quantifying it in terms of minutes. How many times during the week that this happens? And sometimes it's easier to ask when the patient did not engage in the compulsion. And we also talked about the impairment as well. So this is the helpful questions to distinguish behaviors are within the normal realm of development and what constitutes OCD. I wanted to put in the slide deck questions that people can ask about OCD. So I often try to say, these things can happen in people, and asking if, they've had any similar experience. So I like to ask if there are phrases that don't make sense or seem inappropriate, but the thoughts keep repeating over and over again and is difficult to get out of their mind. And when this obsession question gets asked, yes, describe what it's like and ask what do they do in response to it. Do they say anything to themselves to counteract the intrusive thought? I often like to talk about rituals and what happens if they don't do the ritual. Also asking specifically examples if they're saying yes. So I like to ask about hand washing, checking, knocking on wood, rearranging, times you need to repeat statements to other peers or their families. So a lot of times parents might think their kids are being anxious when they keep asking for reassurance about a thing or about an event, but it could just not be anxiety. That reassurance seeking could be an OCD behavior. OCD is a pediatric condition. Um, a lot of OCD starts in childhood. As a matter of fact, there's two peaks to it. Between 9 and 10 years old, 30 to 50% of the cases start at this age range, and there's another peak that starts in the early 20s. There is documented OCD throughout cultures. The prevalence rate is roughly 2%. And males do tend to have an earlier onset than females. One thing that's helpful for OCD in terms of its course, and it will help with diagnosis, is that it does wax and wane. It's not something that's constant. People can have good months or good weeks, but then, especially if it coincides with a stressful event, the OCD symptoms can relapse and be exacerbated. A lot of times, there can be an onset with a precipitating trauma. So it's not the trauma in itself caused the OCD. It's just that this individual was already predisposed to having OCD, and the trauma um, just coincided or uncovered the OCD. Um, but most of the time, it is a gradual um, process, and parents do often have a hard time pinpointing on when the OCD started. A lot of times you'll get the story of, okay, they started washing their hands a little bit more. We thought it was just something that was just a phase, or that they were just nervous because somebody else was sick. But then it just the symptoms keep growing. The good news is that a lot of it can remit on its own. So 50% will have no symptoms in 7 to 12 years, and it is a very treatable condition. Two-thirds to three-fourths of children experience treatment response with an SSRI or psychotherapy. Some things that can lead to a worse prognosis is comorbid psychiatric diagnoses such as tics or anxiety or depression or autism, previous poor initial treatment response, if the symptoms have been ongoing for a while, if there's more of a genetic load for it, such as a first-degree relative having OCD, or paradoxically, if the OCD started and its onset was later on in life. Um, what separates pediatric versus adult OCD is often you'll see a family component to it. It's more likely to happen in boys than girls. There's more likely to be a better prognosis, and the child's less likely to describe it as OCD. And that's something that's very important for pediatricians to recognize, is that many adults with OCD recognize it's OCD and they come with a chief complaint of OCD. With kids, it's going to be stress. It's going to be anxiety. It's going to be parent components, our parents report of they keep washing their hands, or they come in with another psychiatric condition like autism or ADHD or anxiety, and you start noticing that they have to repeat certain things a certain number of times. So often OCD can be missed and underdiagnosed. Um, It is a highly comorbid condition. The most common ones are depression and anxiety. But you also get the other um, conditions that are part of OCD, such as tics and body-focused repetitive behaviors. Anxiety and ADHD are more likely to be comorbid in children, whereas mood conditions and psychosis can be more likely to be comorbid condition in adults. Um, some risk factors for OCD can be genetics. So it does have a shared genetic profile with Tourette's, anorexia, and OCD. If a first degree relative has OCD, they're more likely to have it. And the twin studies do show a genetic predisposition for it. There has been some genes that have been associated with OCD, such as the glutamate transporter gene SLC1A1 or NEUROD6. There are some sporadic and familiar subtypes of OCD. And there's also a brain structure component to it that could be related to previous trauma, even difficulty during pregnancy, if a mother needed more maternal care during the pregnancy period, then that could increase the chance of OCD. So there's not one particular pathway for cause of OCD. There's no one etiology of OCD. The causes for it vary and is multifactorial. So here's the theoretical basis for OCD. Um, a lot of times there's some event that happens out and about. It could be somebody getting sick, being around the bathroom, having a math test, being around a lot of other people, a topic being brought up, and obsession gets elicited. It's very intrusive and it develops distress and shame. But this gets relieved by the compulsion, which provides temporary relief, but it's not an adaptive way to address the anxiety. And oftentimes, what it does is it basically links the compulsion and the danger with the situation. So, for example, holding something that's dirty. A lot of people with OCD have a stressful time holding a dollar bill, for example, because they think of all the other people that held the dollar bill and it's viewed as more dirty, especially because No one hand sanitizes or wipes off a dollar bill. So a dollar bill is similar to a doorknob where they're worried about it being very germy. A lot of times people avoid or they engage in some compulsion to relieve their stress after holding a dollar bill, such as washing their hands a lot. But what that does is it cements the linkage between the doorknob or dollar bill with germs, with danger, with something that can cause them to feel sick. And all these behaviors makes something much more dangerous than it seems. And that's helpful for treatment because a lot of the treatment will work on delinking the stimulus with danger. The CY box is a very helpful OCD screener tool. It generally is conducted with a therapist or a psychologist, but I list it because some pediatricians and PCPs do hand them out, and it is helpful for going over all the categories of obsessions. So, as you can tell from before, the obsessions could take on many different themes. There's sexual obsessions, aggressive obsessions, contamination obsessions, magical thoughts obsessions, which are very common in pediatrics, and even obsessions involving illness or disease. So when we get into treatment, combination treatment is the most helpful. That's just a general theme for most psychiatric conditions that psychotherapy and medications is more helpful than one modality alone. SSRIs are the first line treatment for OCD. And on a population level, the SSRIs are roughly equivalent, but for each individual, one SSRI may be more effective than the others. The doses for medications are usually higher than that of use for depression or anxiety. So I like to think of fluoxetine as an example, like fluoxetine 80 milligrams can be needed for OCD, whereas for depression and anxiety, 20 or 30 milligrams may be more helpful. And exposure response prevention, or CBT, is the first line psychotherapy for OCD. Um, just as the algorithm, it's okay to ask for patient preference. Sometimes psychotherapy may not be feasible for the schedule, or patients may feel initially resistant to taking the medication and they want to feel more in control, so they want to opt for psychotherapy. So it's important to say that people respond best to both, but it's okay to allow the patient some preference if the symptoms are mild. Then, if that's not helpful, adding the second modality and then switching the SSRI to another SSRI. So, for example, switching sertraline to fluoxetine. And then the fourth step is if two SSRIs are not helpful, switching the SSRI to venlafaxine or duloxetine, most often venlafaxine. Clomipramine is also very helpful for OCD. It actually has a little bit more evidence for a larger effect size than any of the SSRIs or SNRIs. It's just that clomipramine has a little bit more side effects. It's a old school antidepressant, and sometimes people get more hesitant with medications they're less familiar with, especially if it's more likely to cause more constipation or more dry mouth or more dizziness. There's several modalities and components of CBT. They provide the psychoeducation. So they talk about the cognitive triangle and about how our behaviors linked the situation with danger. There's a lot of monitoring for obsessions and compulsions that involve diaries and logs. There's a lot of cognitive training. So they talk about reframing the danger and what's another way we could look at the situation, or we talk about cognitive traps. And then there's mapping OCD, which is developing a hierarchy of less stressful situations to very stressful situations. So, for example, if someone has a contamination obsession and compulsion, they develop a hierarchy of what's least germy for them. So it could be touching a pencil or holding their phone, whereas the most stressful is going into a public bathroom. And you basically work on going up the ladder of exposure and response prevention of holding on to that doorknob and not letting go and going through with a therapist of talking out their stress and saying that we exposed ourselves to the situation. We did not engage in the compulsion, so holding on to a doorknob without washing your hands afterwards, and then seeing that they didn't get sick. And that exposure without that negative outcome happening delinks the situation with danger. So they're basically proving to themselves that this dangerous situation or perceived dangerous situation is not actually dangerous. And there's a relapse prevention component to it as well. Um, Practice is very important. In CBT, they often get homework. So, we talked about graded exposure, um, asking them to do these situations without engaging in the compulsions. But it really does require repeated exposures, a lot of practice in between sessions. So you get that autonomic habituation that we've touched a doorknob so many times and I didn't get sick that it's not actually dangerous. And it does have a very high response rate and highly likely to reduce symptoms. So here are some of the different ways we do exposure. We talked about the cognitive interventions, but there also can be imaginal exposures as well. So people, especially for situations that you can't really expose yourselves, like people can have a compulsion or obsession of I can't drive or else I'm going to hit a pedestrian while driving, or I'm going to hit somebody if I go near a lot of people. People can talk through with their therapist of them driving, or they talk through a situation of them being around a lot of other people. So a lot of times you need to work with the therapist to find what else we can do to relieve that stress, like engage in mindfulness, a lot of the coping mechanisms to help relieve that stress. That's not necessarily the compulsion. So you do have to engage in a lot of behaviors that are on the mindfulness, that are within the mindfulness realm. We're now going to move on to the coexisting disorders: body dysmorphic disorder, hoarding, trichotillomania, excoriation disorder, tics, and Tourette's. So we're going to quickly overview this. Body dysmorphic disorder is the prominent preoccupation with an imagined defect in appearance or excessive preoccupation in a slight physical anomaly. For a lot of children and adolescents, it's symmetry with their eyebrows. It's the symmetry of their nose. It could be the size of their eyes, if their face looks symmetrical. And there's a lot of mirror checking attempts to um, hide their perceived deformity. A lot of times people will not leave the house. Um, and that itself can lead to social anxiety because over time they haven't gone outside because of their perceived um, facial flaw that they don't want to leave the house. The treatment for body dysmorphic disorder, a lot of times, is SSRIs can be very effective because it follows the same biological process and it follows the same psychological process as OCD. So CBT can be helpful. It's important to recognize that medical procedures are not helpful for body dysmorphic disorder. Hoarding disorder is something that is more later in life. I brought this up into a pediatric lecture because a lot of times parents bring it up. Um, and hoarding is distinguished because there's an emotional attachment to the possessions, and the obsession is more of a fear of losing items that may be needed later. There are no rituals of it. It's not repetitive. And unlike OCD, the person that is having a hoarding condition is not aware that it's impairing or different from others. So people with OCD have generally the insight, especially in older folks, that this is stressful, this is not within the realm of a normal day to day. But people with hoarding believe that this is the way we should go. Like, I need to hold on to every computer file. I need to hold on to every text. I need to hold on to every newspaper article. Um, and the difficulty with it is it's much less responsive to SSRIs or CBT. Trichotillomania, it's more of the boredom, tension, or physical urge before hair pulling. So obsessions in OCD is more of a thought that goes through their mind. It's an intrusive image, it's a thought, it's not felt within the body. Trichotillomania is something that's done without a thought, as in boredom, or it's with a body tension or a body physical urge. And when people hair pull, the itch, the urge, that knot in that stomach, or that muscle getting tense, it goes away. It's automatic. And for a lot of people, it could be going on for so long that they're not conscious about it. It's just that they need to attract their attention to it for them to be conscious of it. Um, the treatments for it is SSRIs, psychotherapy as well. Now, two treatments that are helpful for trichotillomania that's not present in OCD is habit reversal training and biofeedback. Habit reversal training is something that's very specific. Um, Therapists do need specific training for it. As far as I know, there's only one place in Delaware that does it, the OCD and Anxiety Center in Northern Delaware. For other resources, please contact DC PAP and Mindy for a resource referral. But what it does, habit reversal training does, is it first makes the subconscious conscious. So you work with the patient to recognize what's happening before the hair pulling. So they have to identify the knot, the itch, the tension before they engage in the hair pulling. And what they do is they try to find something else to block the hair pulling. It's a very similar process with excoriation or skin picking disorder, except for hair picking, you're picking skin. It's much more common in adolescents and in women. The most commonly area of the body that's picked is the face. And just like with hair pulling, there is tension and boredom before it, and afterwards there's relief. Therefore, it re-emphasizes and reinforces the skin picking. Um, and just like in hair picking, there is no thought that happens beforehand. It's just that tension or boredom. And the treatments for hair picking is very similar to that of excoriation disorder. Now we're going to get into tics. Tics can be um, very common in the pediatric population, and there is a little bit of an art of medicine to tics because a lot of times tics are mild, they go away on their own, especially in that 8 to 13-year-old age range. But then tics can start being very impairing and tics themselves can be very varied. It can just be a few head bobs here and there to tics that are so severe that they're unable to walk or participate in activities such as softball or baseball. But a tic is a repetitive or brief or sudden or stereotypic movement that occurs in any voluntary muscle. And there's some type of antecedent before the tic. So there's an urge, a tension, a knot, some bodily sensation. I've had kids say they felt nauseous before the tics. So then there's a brief motor movement or vocalization, and then there's relief. The vocalization can be grunting, humming, clearing their throat. It can get more severe and have actual words. But after that tic comes relief. And the tics can fluctuate and be more common in stressful or exciting situations. Um, and what's important about tics is teenagers will say that they can suppress the tics. Younger kids may not be aware of the antecedent or the premonitory urge, but teenagers would say, like, I feel a tic coming and I could suppress it for a little bit, but then the anxiety builds up so much that I have to tic and kind of let it out.
Dr. Pazuniak, before you go
Yes.
on, we did have a question about excoriation. Does it also come and go?
About tics?
No, excoriation.
So excoriation is more consistent than OCD, but there can be a waxing and waning component to it as well. It's very rarely they can go months without it, but it can be worse weeks and better weeks. But hair pulling and skin picking, it's usually present to some degree over the day to day. It's just the amount may change.
Thank you.
Any other questions? Sorry, I cannot see the chat. Yeah. So with tics, often they can appear initially between 5 and 6 years old, but the greatest severity and when people are most likely to see it is between 10 and 12 years old. And about a half to 2/3 of people with tics were resolved by teenage years or early adulthood. So as I mentioned, and this is a common tic where people, scrunch their face, it can come and go, but a lot of times they go on their own. Here are the specific types of tics that are most common. Most of them can occur around the head. So head jerking, eye blinking, mouth grimacing, head shaking. Occasionally you can get complex tics, like people can turn their whole body, people can turn their whole leg in certain situations, and then people can also say words. And if the tics are both motor and vocal over more than a year, it is classified as Tourette's disorder. And I've had a lot of patients that prefer to use chronic motor and chronic vocal tic disorder as opposed to Tourette's, because Tourette's has developed a stigma attached to it, and a lot of times people think of Tourette's as only the most severe cases, but a lot of times people can be diagnosed with Tourette's if they just had motor or vocal tics over 1 year. So you do both need the motor and the vocal tic component to it, and a lot of times they change. But the onset of it has to be before 18 years old. There are a lot of treatment for tics, and it's a little bit similar to hair picking, that habit reversal training can work, except that when they felt the urge coming on, they have to do the opposite competing response to the tic. So if their eyes are likely to close, during the tick, or if their head's supposed to move in one direction, they look down or they keep their eyes open while looking at a screen, for example, or a book to help counteract the tick. And if they're actively doing something to oppose a tick, the more likely the tick will go away over time. So it's a lot of monitoring and looking at symptoms over time. Medications themselves can be very helpful, including clonidine and guanfacine. And then also, depending on the severity, those are often first line, especially if there's comorbid ADHD symptoms. But a lot of times, 1 milligram of long-acting guanfacine, such as Intuitive, can be helpful, or clonidine 0.1 milligrams twice a day. In more severe instances, risperidone or haloperidol is needed. So that's all we have for our presentation.